Okay, good day, and I am Professor Virgilio Novero from the University of the Philippines, Manila, and this is Aspire Ed Talks. The concept of window of implantation in reproductive medicine has evolved over the past 70 years. It was initially understood from a histologic standpoint in the 1950s until my medical school days in the 1980s. But more recently, though, it is being presented in terms of gene expression. This window of implantation is the object of our podcast today. And it is entitled, How Precise Do We Need on the Window of Implantation to Achieve Successful Pregnancy? With us today is our guest expert, Professor Louise Hall, who is based in Adelaide. Professor Hall is a gynecologist and fertility subspecialist, CREI, France COG, with a PhD in Cambridge in the United Kingdom. She founded the endometriosis group, University of Adelaide, and Embrace Fertility IVF. And her research focuses on endometriosis, recurrent implantation failure, and pregnancy loss, and has contributed to shaping global and national treatment directions and in developing new technologies for these particular problems. Professor Louise is a regular presenter at international meetings and media offerings. Welcome to the podcast, Professor Louise.
Thank you so much for inviting me.
Always our pleasure. You are a very regular friend of Aspire. So let's get on with the podcast. We only have 15 minutes or so. So let's get on with it. What is the concept of the window of implantation as a prerequisite for successful pregnancy?
So the concept of the window of implantation is that the way the uterus protects itself is it ends up having a cover of glycoproteins, which when an embryo comes through to implant, progesterone has to start the process of removing those glycoproteins so the embryo can actually interact with the lining. And there's also receptivity markers that come up and receptors for the embryo. And the immune system changes as well. And all of those changes are linked to the timing of ovulation and then the impact of progesterone a couple of days later. And for most people in a 28-day cycle, it will be about 6 to 10 days after the onset of ovulation. And that's usually around day 17 to 21 in that time frame. And what we know from some very early studies is when you introduce embryos in that window, they're much more likely to attach and grow an implant. And if you introduce them on the edges of that window, there's a higher risk of miscarriage. And outside that window, they just don't stick. Implantation is our biggest barrier in IVF for many, many reasons. Some of them are embryo related and some of them are lining related. But certainly some people feel like if you mistime the transfer of an embryo, or if the endometrium hasn't responded to the progesterone change appropriately, the window may not be at the right stage to be able to accept an embryo. So that's the idea of the window of implantation.
Thank you, Professor Louise. You were talking about a little bit more advanced techniques to identify the window of implantation, immunology, and receptors and protein markers. But in the more traditional methods, how are we determining or identifying the window of implantation in more standard ways of trying to get women pregnant in natural conception or in IUI? How were these identified?
So the main way we would identify in natural conception and in IUI is really to do either kits that tell you when the LH surge happens or blood tests to tell you when the LH surge starts, and then you time it to that. And you look at about 7 to 10 days after is going to be the window of implantation. So we really do serial blood tests, particularly around that LH surge. In some units, we trigger to be sure because it can be quite hard sometimes to tell if the LH is high, you may not know if it's going up or down, and that makes a difference. And then you estimate ovulation a couple days later, and then you look to put the embryo back in the window of implantation.
No,
Um,
I can't help but bring up what we used to do 20, 30 years ago when we were doing endometrial biopsies mid-secretory phase and also a bit more recent ultrasound. Can you tell us about those in identifying the window of implantation?
So, a longer time ago, we had something called noise criteria, which is where we look under a microscope and we can look at the changes that suggest the changes that occur in response to progesterone. And we used to take biopsies to see if the progesterone had had the correct effect on the lining and that it was at the right stage. And that was done by very careful and meticulous looking at the tissue. But it was not black and white, and one day didn't equal. They melded into each other and they overlapped a lot, and they weren't quite as accurate. And different people would have different opinions as to which day of the cycle. Although it was quite good, it probably wasn't as precise as some of the other methods. And in the late 90s, early 2000s, we started doing gene arrays and actually looking at the messenger RNA profiles. And
Mm.
initially, we were really trying to see if we could diagnose conditions like endo or, fibroids or other ways of diagnosing gynae conditions. And what we found was the single biggest impact on the lining, and it overrode everything, was the hormonal changes of the menstrual cycle, and that those
Yeah.
molecular profiles were highly related to the stage of the cycle, and they were clearly more accurate than our histology. Now, within them, there are markers, and there are a lot of markers in mice. We found LIF was a very important marker, and we think it has a place in women, but not quite the same in other animal models. And then there are markers such as podocalexin that Professor Guiying Ni works with out of Melbourne. And when that disappears, that shows receptivity in the lining. So that marker doesn't come up in arrays because when we take a whole sample, it's just on the surface of the epithelium. So the levels are too low to be seen. So there are other markers that you can see with special staining or different techniques that don't always come up in your molecular markers. But there are about 5 or 6 different tests designed in different countries, like the epigenomics ERA test
Yes.
or the ER peak test at Cooper's. But there is a Chinese based biotech that makes a window of implantation test as well. And there are several others that have been developed to look at an array of molecular markers. And they're probably all a little bit different, but have similar markers to look at whether the timing's correct.
Well, have they been standardized? Yes, I do understand that there are several in my list here. I think there are 7 or 8, and some of them use 298 genes, others would use only 11 genes. So it's a bit confusing which tool should I use for the times when I think I need to do a testing for the endometrial receptivity. Any advice on that?
I think that it's hard to know which one to use, and obviously cost. I think the biggest thing about the ERA test is that there's a real cost factor to them. These are really quite expensive tests, and certainly in Australia, it's about $2,500 just to buy the test.
Yes.
and we have to send it overseas. Um, the one that was the first one was through EV genomics, and that probably has been studied the most, and
Yeah.
it has had several very large studies behind it, but these are all controversial tests, and I think we still have some development to go in the tests. But the question is, do they actually make a difference? And one of the big problems we have with implantation are there are so many factors that have to be right to get the embryo to implant. So you need to have the embryo with the right chromosomes. And if you don't, the test may be fine, but it may not work because of the embryo. And we can't have antibodies. We can't have anticardiolipin antibodies. We can't have an infection, endometriosis, adenomyosis, or a septum. There are lots of different things that affect implantation, and it may not just be the timing. So it's really hard to evaluate these tests, and you tend to need large numbers. And one of the big problems with the tests is that to get the large numbers, they've used the tests in people who don't have an implantation problem. And they've actually really analyzed most of the tests and done the trials in people who really don't have an implantation problem. And any difference in the test is only going to be seen in a small group of the people that do. So they largely do it in people who've never done IVF before. They're in their first cycles. They're well, healthy people who are going to have a really high pregnancy rate. And the people who have a problem in that population are going to be small. And they're, for the cost of the test, they're probably the ones you want to reserve the test for as a later test down the track if things aren't working. And we really haven't tested in that group, although there is a study that's been registered where they're trying to look at people where they've had recurrent implantation failure and miscarriage to see if they can do it in the correct population. But a lot of our data has either been in very small studies and we get very different results in different studies or in big studies, but not quite in the population that would benefit from it the most. So it's very confusing to know when to offer something that costs our patients a lot of money. Um, but certainly in people who don't have a problem, there's no real benefit, I think. It's just whether the benefit's there for people where you're repeatedly putting back great embryos, chromosomally normal embryos. We can't find any other factor that could account for an implantation issue. And, sometimes the window of implantation appears to be out. You change the window and you get implantation. So it's something that I do use. I tend to use it later down the track in a very specific population. But there's a lot of controversy in it, and a lot of different groups either believe or don't believe very strongly in it. And it's hard because it's very expensive, and the biotechs make a lot of money from the test. And you've got to be mindful about vested interests as well.
So there are a lot of issues there. So one
Yeah.
is that it seems that it's not yet very clear that the test is absolutely reliable because there needs to be more things that need to be well, the test needs to be more robust. There are 7 or 8 different versions of the test right now, and we're not sure exactly which ones would really need to be tested. But judging from how things are going on, you were mentioning about those with recurrent implantation failure as one of those that you probably would be doing this test for the window of implantation.
I tend to do the test if I have someone who've had lots and lots of cycles, that we've got very good embryo quality metabolically. We've had normal tested embryos. I've got no antibodies, no endo, no, I have no answer for some couples. And that's where I think before you think about do you use donor, or which may not work if the window of implantation's not right either. that would be a situation where I would think of using it before when we've got nothing else to go on and we've done a hysteroscopy and I really can't find an answer as to why these beautiful embryos aren't taking. Then I would
Those
consider
those
doing
who
it.
advocate using these tools or these tests more often suggest that there might be 20 to 30% of all IVF cycles who may benefit from this test. Um, would you agree to that number of the number of IVF cycles that probably would need the ERA or the other brand names for the gene expression tests?
Um, I don't think that that would be quite that. I think that's a bit too high, but I think you have to, if you're going to look at that kind of level, there are probably some things you're not diagnosing that need to be treated. So we do a lot of work on diagnostics for endometriosis, and we think a lot of people with endometriosis, the lining of the womb often has there's a feed forward loop with estrogen where the estrogen levels compared to progesterone are a little bit higher and there's impacts on implantation and miscarriage in endo and sometimes treating the endo is what you need to do rather than do an ERA test or adeno is another thing that you might be looking at giving more progesterone or something like that. The other thing is, I think we don't diagnose infection very well. And one of the advantages of the ERA test is you can actually, for very little extra cost, look at the microbiome. And most of the gynecological infections are actually either anaerobes, um, which don't grow in the lab very well. So traditional culture doesn't work very well. Or things like chlamydia that actually grow within cells, and you have to have a cell culture to grow them in the lab. So we don't grow infectious bacteria from the lining very well. And that's where the microbiome test may be helping us. And I think, I'm not sure, you can get contamination. There's a lot of controversy about those tests as well. But I think we are starting to get some tests that are quite effective. And if you don't have access to those, which again are very expensive, you can look for plasma cells. Or you can actually, at hysteroscopy, often see little strawberry petechiae or little microvesicles, which are signs of infection. And in that situation, you'd be thinking of antibiotics rather than doing an ERA test. But again, a microbiome test is where you pull out the ribosome that's in bacteria, and you can actually characterize bacteria in your sample, species specifically, on the basis of the bacterial ribosome that's not present in any human cells in that sample. So I think those tests are starting to develop, and probably as we get better at them, and the ERA test, I generally think about doing both if I am doing one, because the cost is not much different.
So
But
just to
again, there's some controversy there.
So just to summarize for you, before doing these tests, from your point of view, the microbiome, the infections, the endometritis, the anatomy, the immunology, the endometriosis and adenomyosis, all of those need to be ruled out first. And it will only be the last bit before you test for the window of implantation.
Yeah. The other thing we are doing a lot of research on, we have several grants to look at the moment, is looking at not high sugars and diabetes, but actually high insulins, the
Okay.
pre-diabetes. And we're actually about to publish a paper. We've written the draft of it and are submitting it. And the very, very interesting thing was one of the biggest associations was male metabolic disorder and miscarriage.
Hmm.
So,
Oh, okay.
in actual fact, if we're only treating women, it looks like we are missing a lot of what we're doing, even if the sperm count is normal. Okay. So I
Okay.
think when we're looking at implantation failure and miscarriage, it's not just the sperm count, And it's not necessarily we may see some effects on the embryo, like particularly day 5 to 6 fragmentation or slightly poor fertilization. But I think there's even more subtle effects when men have got poor metabolism and maybe high insulins or high lipid, high triglycerides or, impacts on their metabolism because of their general health, or inheritance. So we're looking quite closely at both women and men in terms of metabolic disorder and sleep apnea. A lot of people are not sleeping well at night because their insulins are high and they've got metabolic disorder, and that drops oxygen saturations and impacts on sperm quality as well. So all of those things, kind of we're finding we can change to help implantation, and that may well be in embryo quality, but it also seems to impact miscarriage. So it's how the embryo develops as well. So it's really interesting.
Another concept, Professor Luis, that is brought up by those who advocate testing for the window of implantation is the displaced window of implantation. How often does it occur, and when and why does it occur, if ever you agree that it really does occur, for us to merit testing for the window of implantation?
Certainly when we do testing, we sometimes find it is displaced. And what that means is if you time your biopsy to the time you would usually put an embryo back, and you send it off, it will say that the window is either at the normal, it'll be normal, which means that it's, if you put an embryo back, the molecular signature suggests you're in the middle of the window of implantation, or it will say it's pre-receptive, in which case you need to wait a bit longer till it's receptive, or it's post-receptive. So you have to put the embryo back a bit earlier, and you time to the test. And you really have to try and, as much as you can, do exactly the same cycle. So if you're doing an artificial cycle, you do it again, or if you're doing a natural cycle, you time it exactly the same. So it means you'd be in a natural cycle, you may be in on a Sunday, or, and you have to do the same timing. If it's displaced, you put the embryo back on a different day. Now, I certainly have had some patients where we couldn't figure out anything else, and we had a displaced window of implantation, changed the day, and they conceived. Whether that's just sheer good luck and we got the right embryo, or whether it was I think we had to do it. And I've had several patients where that was the thing that made the difference. So it's always hard. I don't know that you can study that or statistically say that was the only factor, but I think it's hard to walk away and think of a different way of doing IVF, like donor or surrogacy or something like that, without at least checking that for some people. The idea about it, it's hard to know. They've not really drawn any strong conclusions as to why it's displaced. But I do think endo and adeno, often the people who've got a displaced window, I think that feed forward estrogen loop can displace it a little bit. And you can overcome it, I think, probably by giving more progesterone. It tends to be the ratio of the estrogens a bit too high to the progesterone, and the changes don't happen as quickly, I think, and they talk about progesterone resistance in endometriosis and adenomyosis. And we often use a bit more progesterone to prevent that premenstrual spotting. But also sometimes I think the window's a little displaced. But factors that would cause inflammation in the lining potentially would displace the window as well, I think. But I don't think there's any really hard data as to the causes. And there may well be just natural variation, the way we have with the variations in menstrual cycle too. Some people may reach the window quicker than others, just from a natural perspective, in terms of, we're not all the same height. We have a variation there. So I think there's a lot of understanding that we need before we can draw hard and fast conclusions there.
Oh, for our discussions, a lot of studies need to be completed before we any clear recommendations with regards to a precise window of implantation. I think we're almost out of time, so I think we only have time to summarize. So to answer our question on how or how, how precise do we need to be for the window of implantation to achieve a successful pregnancy? Do we need a precise window of implantation in doing natural conception and IUI? And then later on, let's summarize with the needs for IVF.
So in terms of natural conception and IUI, the good thing is sperm live for 5 days and eggs for 2 days. So you do have a window for fertilization around ovulation, and in those cycles, it's going to depend on fertilization and the embryo development, and provided the embryo develops well, it should line up that it's hatching out of the blastocyst at the time where that glycoprotein layer comes down and the receptors come up, and that should all coordinate well. And there's not much we can do about that apart
Yeah.
from possibly giving a bit of progesterone if we think there might be progesterone resistance.
Yes.
And potentially, aromatase inhibitors might help a little bit too in that situation as well, like letrozole. And that might
So timing seems to be standard for natural conception and for
it
IUI.
it's going to be naturally determined, and you're not going to have a look in on that either.
Yes.
So
Okay.
it's really a matter of timing the
Yeah.
IUI to ovulation, and
Yeah.
then hopefully the window of implantation will line up with the way the embryo develops. And we know in time lapse, some embryos develop faster and slower than others,
Right. Correct.
and some of them have the wrong chromosomes or another issue. But as long as it's an embryo that develops on time, it should line up with when the endometrium becomes receptive based on the progesterone shift.
Okay. But in IVF, where with all the new knowledge that we have, which seems to be still not yet absolutely standardized, what can we give as recommendations for WOI testing in IVF, especially in frozen embryo transfer cycles?
So in fresh cycles, again, if we are doing a fresh embryo transfer, we can't really change the window of implantation. And in
Yes.
a fresh cycle, we've hyperstimulated the lining. So the lining
Yeah.
is thicker than it should be. And
Yeah.
one of the issues is if we don't maintain a really high progesterone level, you
Yeah.
might get shedding of the lining and
Yeah.
lose receptivity. So we
Yeah.
usually use progesterone in the luteal phase or HCG or
Yeah.
injectables, progesterones, mainly so we don't shed the lining. And that's because we made the lining really thick. In frozen cycles, we can change the timing. And that is really the only time you can use the ERA test, because you can thaw the embryo on a different day. And if you do day 6 freezing, you can thaw day 6 embryos on day 5 in the right window of implantation if they've been a bit slow to grow, and put them back in the right window. So we wouldn't transfer a fresh day 6 embryo, but we can freeze it and potentially put it back on day 5 when the window
Right.
would be receptive. That's where the ERA might help you in a frozen cycle. It doesn't really help you in a fresh cycle. And we can time it either to when we start progesterone and put it back in the appropriate window, or we can use a natural LH surge. And if there's any doubt about whether the LH is on the rise or coming down, or you can't get 2 blood tests consecutively, we can actually look to see there's a follicle. And if we see the start of the rise, or we can give a trigger. And actually, it's really helpful to give a trigger sometimes because you can just be so much more certain of your timing. So
Okay.
yeah, and there are a few really tricky cycles people are starting to do too, where they use progesterone instead of the trigger. But I think we're going to find them just too complex. I think it's just easier to do the things that we do well at the moment. But there's a few sort of exploratory ways of doing that.
And we were saying that the new gene expression tests like ERA or ER-peak, all of those may be useful in a few patients doing the frozen embryo transfer, but after only having excluded other possible reasons for failure.
Yeah, I think so. And the only other time I sometimes do it is if we have one embryo and we are never going to get another one, and we really want to have done every single thing, because whether it takes or it doesn't, you can walk away and think we did everything. So occasionally I do that for very, very precious embryos too.
Okay, I think we've had a very, very fruitful discussion in that short time that we were chatting, Louise. So thank you very much. And I'd like to wind up by saying, but the testing of it is not necessary in IUI and in natural conception. There might be a small subset of patients in frozen transfer cycles, not in fresh cycles, and we still have to await the results of more studies so that we could be better guided on these. With that, I'd like to close our Ed Talk today and wish to see you again in our next episode of Aspire Ed Talks. Thank you once again.